I appreciate the opportunity to share with every their prolific and extended scientific activities that are actually it's becoming the norm now in Egypt as probably one of the most active societies locally and in the Middle East in the field of assisted conception. So I'd like to thank Professor Hassan for the kind invitation, and I'm just going to address today the fertility enhancing myomectomy, why and how. So it's not when we do myomectomy, but why and how we do them, and how can we put that in the context of infertility management, and how to do a myomectomy in a way to improve the outcome of your subsequent embryo transfer, or address if they could be a cause of recurrent implantation failure or recurrent pregnancy loss. So this is a surgery talk, but from the reproductive endocrinology point of view. This is a surgery talk, but is focusing mainly on how to give a patient a functioning uterus to carry a baby. So, okay, why can't, there we go. These are my disclosures. What I would like to start with, I want to tell you that by age 50, 80% of any women with color, whether it's black or dark, 80% of them will have fibroids of some sort, which means that the journey of fibroids on those patients would have been started maybe at least 20 years ago. So it takes approximately 5 to 10 years for a fibroid to grow from one cell to become a few centimeters. The risk goes down as the light of the skin gets, as the skin gets lighter, but it's not so much difference. It's around 70% in white people. So if you look into the palm coin system, which gathers the visually objective structural as well as the functional causes of heavy bleeding, leiomyomas or fibroids really stands quite well there, whether it is the submucosal components or the other components. And we didn't really have a good classification system for fibroids for a lot of time, which made it difficult to interpret the results of different studies for the different indications, either medical or surgical options, until the FIGO came out with their classification system in 2011. And unfortunately, it's not as adopted as it should be, because I think if we design any study related to fibroid based on that system, we'll be able to come with clearer conclusions and more evidence-based suggestions or treatment alternatives more than what we have. So I'm sure the majority of you are familiar with this system. What I want to really tell you today, one of the key messages is to understand what fibroids are. How do they start? So when you treat them, you are really understanding the disease that you are treating in a better way. So every fibroid starts with one myometrial cell. One myometrial cell. So a normal myometrial cell undergoes what is called a somatic mutation. That's to differentiate between germ cell line mutation, things that were in every cell in the body, or somatic. Somatic mutations can have somatic mutations in your skin, you can have cells in your gut, in your stomach, and obviously in the myometrial cells. There are two common mutations that are found to be present in more than 90% of the fibroids, the MIT12 and HMGA2 mutation. When you get these mutations in the genome, in the nucleus of that cell transforms. It's no longer myometrial cell. It becomes a fibroid stem cell. And that fibroid stem cell, under the effect of gonadal steroids, growth factors, and Wnt beta-catenin system and hypoxia altogether, undergoes proliferation, angiogenesis, extracellular matrix deposition, and that's what makes fibroid, a fibroid at the end. So all of this started from one cell. So when you do a myomectomy and you have a big harvest in a big dish like that, every one of these fibroids is one cell by itself. That has clinical implications, which I will come to in a second. So we all do myomectomies, and we find a lot of redundancy at the end of the surgery. You should never trim that redundancy. The redundant uh, overstretched myometrial cells are healthy cells that they will grow back to their normal size after removing the tumor. And consequently, if you cut them, you're cutting normal uterus and you're making your scar weaker, and you're making the ability of this uterus to carry a baby more difficult. Sorry, I'm getting a lot of calls because I'm supposed to be in the clinic. So my first lesson that I want to share is don't trim. What happens to the fibroid if we do not do anything? If we look into the natural history of fibroids, 21% of the fibroids would show evidence of spontaneous regression. So really, you don't need to treat everybody. And once you see a big mass in the uterus, you have to put it in context and decide about what the best treatment action is. So in terms of symptoms, only 50% of fibroids are symptomatic. And there are three key symptoms: bleeding, complaints, irrespective of the type of bleeding; reproductive dysfunction, irrespective of the type; and there's a mass effect related to the mass present. All three together definitely affect the quality of life. So nobody would argue that a treatment would be necessary for symptomatic fibroids. That's not what I am discussing today. I'm not going to talk about symptomatic fibroids. I'm talking about asymptomatic fibroids in the context of infertility or in the context of reproductive failure. We have different options: medical, surgical, interventional. And for the medical, we have the symptom management and the targeted therapies. We have two targeted options, or targeted medical therapies that we can use to treat fibroids: the selective progesterone receptor modulators, the ulipristal acetate, I think it's available in Egypt now, and the old known GnRH analogs. We'll talk briefly about both. And surgically, really, you have the myomectomy and the hysterectomy and the common two. This is a complicated algorithm I'm happy to share with you, but to make it simple, the only one type surgery that's suitable for a patient who is infertile, if surgery is indicated, is a myomectomy. Anything else really doesn't help the infertile patient that much. There are some additives here and there that we can talk about at a different topic, a different time, but myomectomy is a key surgical intervention for patients with infertility. What is the story behind fibroids and infertility? The first key factor that you want to know is age, because not every patient with fibroid is infertile because of the fibroid that's existing in our uterus. It could be a completely incidental finding, and the patient has another cause. So don't get sidetracked. That's number one. Number two, we know that fertility declines with age, and fibroids increase with age. So the two curves meet at a certain point of time, maybe even earlier than the age of 40, around the age of 35. So if anybody walking into her clinic, 35 or older, you would have some fibroids somewhere, but she has more pressing issues, most likely, needs to be addressed. Most importantly, her ovarian reserve and egg quality secondary to the effect of age. I want to share this figure with you, which is coming from one of the biggest IVF centers in the United States. Irrespective of age, irrespective of you have fibroids or not, irrespective if you do axial conventional IVF, irrespective of your ovarian stimulation protocol, if the day 3 FSH is around 18, the live birth rate is close to 0. So really, we have to think oocytes and eggs in addition to everything else. So fibroids are present in around 70% of patients with reproductive age, in the reproductive age category. 5 to 10% of patients who are infertile have fibroids. But one of the few studies that looked into what is the percentage where fibroids could be the sole cause of infertility, it's only around 2 to 2.5%. Like endometriosis, around 12% of women undergoing IVF anywhere in the world, they have fibroids of some sort. So fibroids and recurrent pregnancy loss, if there is cavity distortion, there is a big study here, it was more than 1,000 patients that showed that it does not affect early loss, because most of early losses, less than 10 or 8 weeks, are secondary to aneuploidies. They have nothing to do with any other factors. But it does affect late first trimester as well as second trimester losses. And when you remove them, you impact the outcome positively. If the fibroid is not distorting the cavity when it comes to recurrent pregnancy loss, it was not found to make a difference to remove the fibroids or not. So according to the type of the fibroid, we agree that subserosal would not have any impact. Cavity distorting fibroids will have impact and they need to be treated. And non-cavity distorting is kind of controversial. What happens to fibroids when the lady gets pregnant? In 60% of the time, there will be no change based on data. 30% of the time, it may increase in size. And actually, in 30% of the time, it may decrease in size during pregnancy. So that's, again, when you get this question from the patients. Another question that you are faced with when you counsel your patients who are undergoing IVF or ICSI, does the number of myomas removed affect fertility outcome? So there was a study that came from Cleveland Clinic, where I used to be actually, that looked into that. And they found that if you're removing more than 6 fibroids, the likelihood of conception is significantly less compared to if you're removing more. So the bigger the harvest, the less likely the successful subsequent pregnancy will be. And it's intuitive because there is a lot of cavities left in that uterus secondary to these fibroids. And if you remove that many from a uterus, believe me, you're leaving some behind. You can't remove everything. And a patient who developed that many, she would have multiple mutations in her myometrium that will pop more fibroids in the uterus even after removal. So what does the guidelines tell us? For asymptomatic fibroids in patients who are contemplating pregnancy or undergoing assisted reproduction, the Asrn Guidelines tells us that myomectomy can be considered to improve the pregnancy outcome in cavity distorting myomas. And quote unquote, cavity distorting myomas does not necessarily mean submucosal fibroids only. It could be intramyometrial fibroids, anywhere from Figo-type 3 to Figo-type 6. And really the best way to assess that is an MRI, particularly if the number of the fibroids are more than 5. Because the cavity can be elongated, which is a form of distortion, could be completely displaced, but when you put the hysteroscope in, it is normal cavity, it's not, there's no bulge inside. So we have to kind of change our concept of what a cavity distortion means. The second recommendation from that guideline is that generally myomectomy is not advised to improve pregnancy in non-cavity distorting myomas. Yet it can be considered in certain situations, like for instance, if there is a severe distortion of the pelvic anatomy that may be complicating access to the ovaries for egg retrieval. So, and again, we are talking here about asymptomatic fibroids otherwise. So there are refuted reasons for myomectomies according to this guidelines. You don't need to remove the fibroids if it's the uterus more than 12 weeks and the cavity is normal and no other causes to explain the infertility. If you cannot palpate the adnexus, this is not an indication. And you cannot use the what if reasoning. What if the fibroids become bigger over time, and what if the patient become asymptomatic? You have to address it at that time, but you don't need to preempt and remove them if there is no strong rationale for that. So I don't know how much time I have, but I'll spend whatever is left to focus more on the surgical technique related to myomectomy. So again, showing you an MRI of a patient and a hysteroscopic view of too many fibroids inside. You have, while you are addressing this and trying to remove, no matter what you do and how good of a surgeon you are, you will end up with suboptimal cavity. And the outcome may not be as good as a patient without these issues. So I want to show this specific picture. If you look closely here in this uterus, that is above the level of the umbilicus, almost reaching the xiphoid process. And when you really put a hand on this abdomen, you say, oh, this is a patient that I have to take to the OR to optimize the uterus? Really not necessarily. Because if you look into this MRI image, you would find that the biggest fibroid is here. It's around 1 to 2 centimeter. And the endometrium is really studded with fibroids in every single corner. So this patient has more than 50, 70, 80, 90 fibroids. Really, surgically cannot win this battle. And that may be a patient that should consider long-term medical treatment and then draw fluck after that for embryo transfer. But touching a uterus like that is just telling you're just going to do a hysterectomy at the end, basically, during that surgery rather than. So with some medical treatment available, it's probably she will do better with medical treatment rather than surgical. The fibroid distorts the vascular anatomy of the uterus in a very haphazard way. We all know that the uterus is supplied with a pair of the uterine arteries that come from the anterior division of the internal iliac, and then you get the spirals, the arcuates, and all the branches. When you get a fibroid, every fibroid, this is the vascular corrosion casting where the uterus was removed, fibroid was dissolved, and the blood vessels were preserved. So the cavity you're seeing here is where the fibroid used to be. And this is a vascular mesh that's surrounding the fibroid, even for smaller ones all over. So the concept of a pedicle for the fibroid is an old one. Fibroid is surrounded with a very dense vascular mesh that you have to go below when you do surgery in order to be able to do a myomectomy with less blood loss. So the changes that happen in the uterus secondary to the fibroids depends on the size of the fibroids, the size of the uterus, the depth of the endometrial cavity, the number, and the location. And there are some indications for targeted preoperative therapy using GnRH analogs or the sperms. A systematic review that looked into that, and a Cochrane review, 38 RCTs actually looked into this. So there is a significant improvement of the hemoglobin. That's probably the best one for patients who are anemic. And there are also some suggestion that it decreases the fibroid size, blood loss during the surgery. And if you're doing a hysterectomy for this patient, it would have been probably a little less easy, less complicated, with less likelihood of having post-op complications. I want to share a take-home message here. Should we use preoperative GnRH agonists routinely before myomectomy? The answer is no, irrespective of, and that's the reason. So the effect size in terms of blood loss that you're going to get from GnRH analogs is, according to the RCTs, around 67 milliliters. So if you pre-treat for 3 to 6 months, you're going to get 100 cc's less during your surgery, irrespective of your technique, whether it's laparoscopic or open. So would that justify the treatment? That's one question. The other, the effect of the GnRH on the plane of the fibroid will be making a difference in the surgery and may make the surgery more difficult and the fibroid more difficult to inoculate. There is no difference in the rate of blood transfusion, but the only indication for me in our practice is if the patient is anemic. It really does very well in stopping the period and recovering the hemoglobin back to normal in order to proceed with the surgery after that. But if the patient is normal hemoglobin, then probably I don't see a big value for pre-treatments. How about intraoperative interventions to decrease blood loss during myomectomy? There are lots of options. I'm going to focus on from the practical point of view. For those of you who are interested, there is a systematic review that they can read. The first one I want to share with you is vasopressin, really. And not about all the facts that you see in front of you about the half-life and how much you can use. It's about how to inject it inside the uterus. Actually, the way we're taught is to inject it intramyometrially. I think we have to change that concept and think about injecting the dilute vasopressin in the pseudo capsule below the vascular mesh that I showed you. And I'm going to show you some live examples, actually, rather than the dry theory. So this is a laparoscopic myomectomy. Here is the injection needle. that we use, and then we go deeper all the way. How do you know that you are in the right space? That's the first thing you do. If you look at the syringe here in my hand while I'm injecting into into the space, you could see how fast and easy that is flowing with one finger in the space. I stay in that spot and I continue to inject 30, 40, how much I need. So you could see how peripherally spread the injection is, because this cavity is a continuum. It's all over the fibroid itself. And when you do it this way, you don't only do the vasoconstriction that you want to, you also amplify the perifibroid space, which makes its identification easier. In addition, you will have no hard time identifying the plane when you go and cut into that uterus. And that can push the endometrium away. If that fibroid is type 3 or a type 2 that you are doing laparoscopic myomectomy for, the myometrium will be pushed away from you during the dissection, so you don't enter the cavity. And of course, the uterine contraction. So remember, if you are pushing hard with a syringe, you're not in the right space. Look for the right space. I'll show you another video clip. This is a follow-up video clip for the same exact patient that I just showed you, using the harmonic scalpel, cutting deeply all the way to the fibroid. From one cut, you are very much in the right plane in order to get to where the fibroid is. And at that point of time, you can go ahead and do bidirectional dissection, irrespective of whatever you're using, harmonic scalpel or even monopolar hook. But believe it or not, I do more blunt dissection and pushing and pulling without using any source of energy when I use that technique, more than what I used to do before. And most of the fibroids come out nicely, as you can see in that one. Again, how to make sure that you are in the right space. Watch this. You would see a sudden release of the needle when it gets into the space. It's the exact same feeling that you get with a Verese needle when you put it inside the peritoneal cavity. That sense of sudden release will definitely get you in the right space. And then you can go ahead and inject whatever you want. So just gonna skip that for the sake of time. I also use 1 gram of tranexamic acid with the uterine incision, and it has been shown in some studies that decreases blood loss. And I use misoprostol rectally. Once the patient is in the OR, I put 800 micrograms if I am doing a polymyomectomy, or 400 if I am removing 2 or 3 or 4 fibroids. I use tourniquets. Yes, I do. Sometimes when the number of fibroids is more than 5, it has been shown in systematic review that decreases blood loss. And the way I do it, I use a Penrose, but if you don't have the Penrose in your hospital, you can use a Foley catheter. The important part that I want to share with you, you can see there is no tail here. So you put it around the uterus, you pull, put a clamp, keep pulling, put a clamp, keep pulling, put a clamp until you can't pull anymore. And then I tie it with a stitch and cut all the redundant stuff, because I do most of the myomectomies using a fan steel incision. And then I don't have a lot of tail of plastic in front of me during the time of surgery. So that's kind of described the Katensky clamp. And these are bulldog clamps that we use sometimes for laparoscopic myomectomies. So sometimes we put tourniquets at the time of laparoscopic myomectomy too. As you can see here, we open the anterior leaf of the broad ligament and then go and dissect until you reach to the uterine. And after you identify where the uterine out, you create a window in the posterior leaf of the peritoneum. The posterior leaf of the broad ligament. And you put the tourniquet around that way. You just gonna run it faster to show you. So you create the window on both sides, and then you pass, because there's a Penrose here. So that's what we call as Penrose. And then you pass it anteriorly, and you can put the bulldog clamp on you, or you can tie it. Laparoscopically, you put a clip on it, whatever you want. So there is a systematic review that was published in Fertility Sterility looking into both temporary and permanent uterine artery ligation at the time of myomectomy. And it decreases blood loss by 100, which is not that much. number needed to treat in terms of reducing blood transfusion is around 14, and longer OR time, up to 10 minutes longer. However, if you're gonna use uterine artery maneuvers of any sort, in my books, it should be temporary. You shouldn't do any permanent ligation because most of the studies are low quality with modest effect on the surgical outcome. And temporary occlusion is equally as effective in terms of blood loss and in terms of healing subsequently. And we don't have any long-term reproductive data on the reproductive outcome if we do permanent ligation of the uterine artery. Well, this is a systematic review that I shared with you about intraoperative interventions. So there is a moderate quality evidence to support misoprostol and vasopressin, and low quality for the others, including the tranexamic acid. So planning this incision, you can decide a respective, really plan anterior or posterior incision, but remember, ovum pickup happens on the posterior aspect of the ovary. So if you're doing posterior incision, you have to be careful about that and do adequate closure. The incision has to be deep enough. You have to use bidirectional dissection. You should not start dissecting before getting into the right plane, because if you start doing that earlier, you'll end up with a lot of bleeding and a lot of blood loss during the time of the myomectomy. You can use with or without energy sources, and you have to do a lot of traction, counter-traction. I find the laparoscopic 5mm tenaculum more helpful than the myoma screw if I'm doing laparoscopic cases, because you can put it and take it out easily and change the position easily too without wasting a lot of time. This is a laparoscopic submucous myomectomy. What I want to share with you here, that regardless of their size or location, when the fibroid are close to the cavity, even if the cavity is not distorted, they may have a paracrine and molecular effects on the adjacent endometrium that are extensive enough to cause excessive uterine bleeding or defective implantation. Consequently, they may affect your outcome negatively. You could see here I am filling the endometrium here with methylene blue. You could see the blue color here, and as I move here, peeling off the fibroids of the endometrium, you see how close they are. And again, mostly blunt dissection from that point on to avoid destroying the lining with a sharp dissection. This is another version. This is another patient. You can also use sharp dissection. And when you use sharp dissection with scissors, we use what we call as the onion skin technique. So you are like if you're peeling an onion, basically. Then last message I want to share is when you do closure, shouldn't count layers. You can do as many layers as you want and as it required, actually. So if you have a big midline incision somewhere on the anterior, but you removed 6 fibroids from that incision, every single cavity has to be closed independently, and then the rest of the myometrial defect has to be closed in layer. You can use, this is a laparoscopic case using barbed suture. This is a horizontal incision. This is a vertical incision during the time of the closure. And this is kind of the finished product at the end. At the end of the myomectomy, you have a lot of blood clots in the pelvis. Please do your very best to remove. And I want to share with you that water is better than saline, because saline could be more adhesogenic, particularly for a patient who is trying to get pregnant on her own. This is a systematic review that looked into the different types of barbed sutures. I don't know if they are available in Egypt, so I don't want to spend a lot of time here. Since I use adhesion barriers in the form of interseed after laparoscopic and open cases, and since the morcellation story started in North America, we don't do mechanical menstruation, although we just got a release from FDA that is more flexible. We do many laparotomy, 1 or 2 inch incision at the suprapubic region, like a suprapubic port, to retrieve the fibroid from, using this retractor that you see in front of you, which we call the Alexis retractor. So in conclusion, understanding the vascular anatomy is a key, and not only for successful outcome during surgery, but also to counsel the patient appropriately about our subsequent outcome with infertility treatment in general. There is a good evidence to support both vasopressin and misoprostol, and I add here tranexamic acid as well. There is a fair evidence to support temporary uterine artery occlusion against permanent uterine occlusion. Proper surgical technique is mandatory. We are all these facts we know. Laparoscopy over advantage of shortened recovery for those patients. There's no difference in the reproductive outcome in the experienced hand. The main technical experience required for laparoscopic myomectomy is suturing. If you are comfortable with suturing, that's totally fine. You can do any myomectomy with a straight stick, but robotic assistance can be used solely for the suturing part of the myomectomy. Most of the myomectomies that robot was involved, it's mainly for suturing the bed. That's it. Thank you. I went over time a little bit, so I apologize for that.
Thank you, dear Professor, for the nice, comprehensive, and informative presentation. Really very comprehensive.
Can you stop sharing?
Yeah, stopped. Can I ask at first a small question before the panel questions? As regards broad ligament myomas and subserosal myomas prolapsed in the Douglas pouch, peduncle subserosal myoma prolapsed in the Douglas pouch, do you prefer removal before IVF or not? For fear of torsion or enlargement in size and pressure over pelvic vessels or ureters. What's your opinion?
I already insinuated the answer in my lecture, and that's a good question. Thank you very much. So you should not remove fibroid for fear of anything, symptoms, or for fear of complications, because the complication risk for fibroids really, how many, well, Dr. Hassan and Dr. Mohamed are the most senior people here. How many times did you see a torsion from a fibroid that's pedunculated? Very unlikely. The same for malignancy, it's low. So the only time I consider removing these fibroids, if there is pressure on the ureter, like if there is hydros, because if it's broad ligamentary, I would do kidney ultrasound in this patient before I do anything else, before the MRI for the uterus itself. If the kidney is showing back pressure, definitely I would remove it, because it's now kidney saving surgery rather than fertility preserving surgery. If it is blocking access to the ovaries at the time of retrieval and IVF is indicated, you're not doing the IVF because of that, then yes, you go ahead and remove that fibroids, and I have done a few of those, because really you stimulate the ovaries all the way under the diaphragm. What you're going to do, it's really wasted eggs, and this patient cannot get pregnant otherwise.
Thank you. Dr. Hassan, you have a questions?
Professor Bedaiwy, thank you very much for a more than excellent presentation. We asked you this in a very short notice, and you replied to us generously. Thank you very much. Can you elaborate more on medical methods for decreasing bleeding during myomectomy?
That's a great question. Well, again, thank you for the kind invitation, and I apologize again for not sending the questions because I didn't have time. So when we talk about medical treatment, we have to differentiate between two major categories: temporizing measures and targeted measures. What is the difference? Temporizing is you putting a seal in the endometrium to prevent bleeding. Targeted, you are treating the fibroid mass itself. We have only two options for the targeted treatment that affect the fibroid cells and affect the collagen matrix around the fibroid cells: the GnRH analogs and the sperms, the selective progesterone receptor modulators, ulipristal acetate. And more recently, there are phase 2 trials on the Elagolex, which is oral GnRH antagonist, but it's not marketed for fibroids yet. So realistically speaking, that's the way I think about it. You're talking about two: the ulipristal acetate and the GnRH analogs. We're getting more issues with ulipristal acetate lately because of hepatocellular failure. There are 5 cases of hepatocellular failure all reported in Europe, and ended up with liver transplantation on all 5. Which definitely put this medication, was an excellent medication, by the way, when we started using it, stops, patient is hemorrhaging, excuse me, the hemoglobin is less than 6, in less than 10 days, she's completely amenorrheic and 80% of the time. So it was very good. But liver impairment is a big issue. Now the recommendation that we don't use it more than one course. The patient has to do ALT and ST before starting the treatment and every month while on treatment. So you can't use it technically more than 3 months. And in a country like Egypt with the Hep B and Hep C, our patients are more vulnerable than any other population to develop. And I'm not sure how compliant our patients are to do liver functions every month while they're on treatment. So that is something I really want to share, because if you want to decide to use this treatment, you have to be on your toes while you are using it, not to kill this patient from liver failure. And I'm not sure that she can get liver transplantation as soon as they can do somewhere else. So technically speaking, if I am thinking medical treatment before surgery for patients who are hemorrhaging, I cut it short and I go directly to GnRH analogs with AdBac or with AdBac if I'm using it for a long time. And AdBac I prefer is progesterone in this situation rather than estrogen. Something like norethindrone acetate 5 milligrams daily. It's good enough to alleviate their hot flashes, and it's temporary anyway. And only if they are anemic. But if you're going to use it long term, you can use it long term. I have patients on GnRH analogs for 5 years, 7 years. I remember when I was with Bob Casper in Toronto, who published a paper on fertility sterility, that we used GnRH analogs for up to 10 years in patients with adequate AdBac, with no effect on their bone mineral density. You can look that up. It was more than 10 years ago. So I'm very comfortable using GnRH analog because it's a safety proven profile. Although FDA says that any use beyond 1 year is kind of empiric, but if the patient is happy, you discuss that with her and you get control to transition her into menopause, for instance, or the patient is too many fibroids to remove and she's hemorrhaging and receiving transfusion every month, then definitely medical treatment is helpful. Or one of the patients like the one I showed you the MRI of, where is there fibroid in every single myometrial cell, that's probably but you can use combinations if the patient cannot afford. The combination that may work is maybe a Mirena IUD with some form of progesterone orally. But Mirena alone in a big fibroid like that, I'm not sure how big. If it's one fibroid or so, then maybe you can try it first and see what happens. But if you are using one of the temporizing measures, usually you have to use more than one. So more recently, we started to use, if the patient already have a Mirena, we can add Elagolix off-label because it's approved for endometriosis, not for fibroids yet, on top of the Mirena IUD. For patients, for instance, if they have risk for osteoporosis and they cannot use GnRH analogs, or they are already in heparin, like a patient I have, she has pulmonary embolism, she's already on anticoagulation in the form of heparin, which is as osteoporotic by definition. So I can use GnRH analogs. So you have to individualize at the end of the day.
Mahdi, you have questions on the questions and answer section. Please ask them for Professor Bedaiwy.
Up to which size of fibroid we can use sperms?
Well, really use sperms for function. So irrespective of size, basically, you use it for bleeding. So there's most of the studies, though, looked only into fibroids that are less than 12-week size. And for obvious reason, because this is an industry-sponsored study that was published in the New England Journal of Medicine. There are 2 back-to-back studies and the follow-up studies, because if you have too many fibroids, that's not fair for the medication to be tried on those fibroids because they are not the norms. But in theory, you can use it irrespective of the size to stop bleeding. And actually, people even extend it to non-fibroid causes of bleeding. So if nothing is working, people have used it for patients with adenomyosis and patients with idiopathic menorrhagia due to coagulopathy, like factor V Leiden deficiency and stuff like that, just to stop the bleeding until you know what you're going to do with this patient. Because these poor people, they have a positive blood opened all the time, and some of them require frequent blood transfusion. So short answer is yes, you can use it irrespective of the size, provided that you're monitoring the liver carefully.
A closure of large bed of myoma without trimming.
Well, remember a few things here. Number one, the uterus has a great remodeling capacity. So for irrespective of how ugly it looks at the end of the surgery in your eyes, it will be perfect if you do a transvaginal ultrasound on those patients like 6 months later. So if you have a tumor in your biceps muscle, that's a myoma in the biceps, and you go ahead and you remove the tumor, all the muscle fibers around the biceps will be overstretched and will be redundant. Will you cut half of your biceps muscle at the end of the surgery to get a beautiful looking biceps? You'll end up with a paralyzed arm at that. So think of the uterus that way. So that's the first one. So never remove any healthy tissue from any patient in general if it's healthy. So redundant tissue is not a pathology. It is a healthy overstretched tissue secondary to existing pathology. You remove the pathology, it is expected to go back to normal after removing the cause. That's number one. Number two, I'll tell you what I do when I have a deep cavity. So I am always keeping memory or asking whoever is assisting me to keep track of how many fibroids we remove from each incision. So we go into the main incision. I don't touch the main incision until the very end. So I go in every corner where a fibroid was removed. I put an Alice at the bottom, at the very bottom. Some of these beds are so deep, like the patient that you told me about, which has a broad ligament fibroid. After removing a 15 centimeter fibroid, you would have a very deep cavity. What people do, they go as far as the end of their needle holder goes. This is, to me, this is not right. You will leave a big cavity. You go all the way to the bottom, grab the bottom with an Alice, that's your base. Start there and walk your way up, close that cavity, go to the next cavity from within the same incision. And after you close these individual cavities, then you go to the main cavity and you do layered closure. Typically, I don't go more than a centimeter or two actually for each layer, 2 or 3 centimeters. So sometimes I end up putting 2 or 3 layers. Sometimes I end up putting 5. So it is, you want that to be sealed shut. The biggest enemy for a good scar is a hematoma. If you leave a dead space in a patient that already used a tourniquet, used vasopressin, and used misoprostol, all of these medications have half-lives, and you're gonna remove your tourniquet at the end. So 2 hours post-operatively, that cavity that you left will have a big hematoma. I think there was a good study actually that came from Asyut when I was working, and I'm still working there, by the way. Dr. Atif Darwish, he did a very good study actually when he monitored the myomectomy, the hematoma after myomectomies, and they stay for up to 6 months after. So if you don't really close it well, you will have a hematoma of some sort. I know we are reproductive endocrinologists. Lots of us stopped practicing obstetrics. You can see those patients where they are labor or have spontaneous rupture of their uterus around 30 weeks, or they have a scar dehiscence, or they have a placenta accreta, which it's increasingly becoming common now everywhere. So I really want you to be careful about the cavities. I know you'll be exhausted at the end of the surgery after removing fibroids from the tent. A lot of us leave it to the trainees, like the assistant lecturers, which all due respect. I insist on staying until the last stitch is put in the myometrium before I leave. And by the way, I close the parietal peritoneum in myomectomies always, because that uterus, if you have an anterior incision on the uterus, it will stick to the anterior abdominal wall, which can lead to infertility by itself. But again, this is another discussion.
Thank you.
I think I took more time than what I deserve.
No.
Okay.
Can we evaluate endometrium in a large fibroid with MRI?
Sorry?
Can we evaluate endometrium in large fibroid with MRI?
Yes, with contrast. So if this patient takes contrast, Let me, I already stopped sharing screen. It will appear as bright white cavity. If there is any defect in it, you will see it as a bulging. And I think you have to work some agreements with anybody who owns an MRI in your city that wants you to send him patients. I want to share two messages here. First, stop reading the report about MRIs before you see the images. So whenever I send a patient to the MRI, I don't look at the report at all. I pull the images in front of me and I scroll down and I go through everything first before I read whatever the radiologist interpretation of this myomectomy. So really very simple software that you can get, particularly if you have a practice that's surgically heavy. And they send you a CD with an auto run function on it. You don't need to install any programs. That you can really study the topography of the uterus even better than open surgery. You would know almost every single fibroid. And whenever I'm doing laparoscopic or open myomectomies, I have the MRI images open in front of me. And I refer to that a lot, particularly in patients with multiple fibroids. So yes, you can see the cavity with contrast. So you have to order an MRI with contrast to be able to see the cavity.
Can I do myomectomy without bandage, just with securing hemostasis with diathermy? Is there a risk?
You can do without tourniquet, he means. So without tourniquet, yes, you can, definitely. You don't, these are all options. So for 90% of, I would say even 95% of my laparoscopic myomectomies, which represent probably 80% of the myomectomies I do, I don't use a tourniquet at all. I use medications. I use proper surgical technique. I inject vasopressin in the right place and just follow the rules of surgery. So yes, absolutely. More so for open myomectomies because people in Egypt are have a great experience in this and everywhere in every city. So.
Concerning tranexamic acid, do you inject it with vasopressin or alone?
No, this is important. Tranexamic acid is not to be injected in the uterus. It's an intravenous medication that I ask the anesthesiologist to give. And you have to be cognitive of that because it has a limited lifespan. There's contraindications for this medication. For patients who are bronchoagulopathic, you shouldn't use it. So, so it's an intravenous. Usually the anesthesiologists give it. I don't give it early because by the time we prep the patient and put the patient in Trendelenburg position, it's already out of the system. The benefit is gone. So when I start cutting into the uterus, I ask him to give 1 gram of tranexamic acid once. So I use all three all the time. The minimum I use, the vasopressin, which is still available in Canada, and the misoprostol rectally, which is available in Egypt, and the tranexamic acid intravenously. So remember one in different routes, rectal, intravenous, and intrauterine.
Types of sutures that to close myomectomy.
Well, I use mostly V-lock for the laparoscopic cases because it's easier and faster. I'm not sure if it's available in Egypt, which is a barbed suture that you don't need to tie. But I use 2O Vicryl on the myometrium, and I use closer to the lining, particularly if I ended up in the lining inadvertently or intentionally. I use 2 or 3O. I try to not to put any sutures inside the cavity. I just try to use, I suture the endomyometrium rather than the myometrium itself. And then I carry on with 2O Vicryl until I close the bed. And then you can use 3O or 4O monocrol, which is like a processed catgut of some sort on the seromuscularis at the outside for the baseball stitch.
When do you advise your patient that she can get pregnant afterwards?
That's a difficult question. Thanks for asking this one. So basically, my baseline is 3 months. And if the patient is younger and I'm removing a lot of fibroids and age is not a concern, I even ask them to stay for 6 months. I have pictures of patients 3 months after surgery where I can still see all the sutures that I put in the uterus. They're not fully absorbed yet. However, having said that, I have patients got pregnant after 1 month of myomectomy, actually. And this is a patient that kept me on my toes for a lot of time because she was in fertility 8 years. We did an IVF actually on her, and then she had 8 good quality frozen embryos. But there was a big myoma that was to some extent distorting the cavity. Did the myomectomy, and I told her not to get pregnant. She didn't listen, she didn't use protection. She said, I have never been pregnant for 8 years. I would never get pregnant on my own. She got pregnant next month. She delivered safely, alhamdulillah. But this is a draw of luck. So we don't, بعون الله طبعا. لكن it's, so you should not repeat that. You should be firm.
I will not.
3 months. 3 months.
3 months.
3 months is the baseline, and increase if they are older, if they are younger, sorry. Up to 6 months is fine.
Yeah. What do you think about high frequency, high intensity focused ultrasound ablation in nullipolar?
Well, I can answer the other question that's parallel to that, which is the radio frequency ablation using diathermy, because I was part of a phase 3 randomized control trial that looked into this. We didn't find a difference, unfortunately. High frequency ultrasound, we don't have studies that looked into. We're talking here from the reproductive point of view. If we're talking from the perspective of a patient who has 3 children, you can do whatever you want. But from the reproductive point of view, we don't have any follow-up studies on those patients. And the fibroid stays in the uterus. It does not go away. It only shrinks and it becomes less active. Whether this is going to affect the reproductive function or not is a question yet to be answered. So you can use it if you have no other options or surgery is contraindicated, but you have to be careful because we don't know what happens to pregnancies after that.
Do you prefer to do your layers with interrupted or continuous technique?
A combination of both, actually. The deeper the cavity is, I use interrupted because I get better control. The more superficial layers where you could see that your layer is going tight all the way in front of you, I use running. So use your clinical judgment. There's no clear prescription here.
In case of severe bleeding during surgery, can we use more than one medical treatment for the same patient?
You can use as many medical treatment as you want, and you don't need for severe bleeding to happen. You can use preemptively. So I'm sure every gynecologist and obstetrician in Egypt has a misoprostol in his bag somewhere for induction of labor. Just get that one and put 800 in the rectum. Really, they work very well. We use it for postpartum hemorrhage. So you can definitely use more than one modality for bleeding.
Bilateral uterine artery ligation during myomectomy, is it a reasonable hemostatic option?
I did one yesterday. Again, really rarely. When I said did one in yesterday, this is probably the only one I did in the past 3 years where I need to do permanent ligation of the uterine artery because the ureter was in the way and the fibroids were extended everywhere, and I have to do it that way. I don't have other options. So I don't recommend it unless you have hemorrhage that you are doing life-saving, then you can do anything to save the life. You can do uterine artery ligation, you can do anterior division of the internal iliac artery. The question now is not about fibroids, it's about the life of the patient. Then whatever is necessary to save the life, you should do.
Do you get the chance of vaginal delivery after laparoscopic myomectomy or not?
Well, there is lots of literature that's accumulating about that. Be careful because if you don't have good record, we have good record system, we're lucky here. So I can go back and retrieve the myomectomy report that the patient did 10 years ago. And I know what kind of suture he used and how many layers and how many fibroids were removed at that time. For the vague history that we may get in Egypt and the lack of reporting and the lack of centralized health system, you have to be careful about that. But it's possible, it's doable, but there are specific criteria that you have to fulfill.
3 centimeter intramural myoma, not encroaching endometrium. Is it treated by surgery?
This patient can get pregnant on her own without any problems. And if she has 10 blastocysts frozen and you transferred 7, and she's not getting pregnant and you're not finding any other cause for recurrent aneuploid embryo failure, then by that time, this fibroid may be 5 centimeter and you can remove it.
Corneal fibroid, does it need certain precautions during removal or not?
If removing that fibroid going to destroy the tube on that side and this poor patient cannot afford IVF and the tube is not occluded, I wouldn't touch it if it's small and if it's not contributing to her symptoms. Even if I'm doing myomectomy. Why? Because you're depriving her from her ability to get pregnant on her own, which she could basically after your surgery. So corneal fibroids blocking, if removing them going to block the tube on that side, I wouldn't remove them.
I faced the case of a malignant changed fibromyoma. What management? Unfortunately, case died.
Can you repeat this question again, please?
I faced the case of malignant changed fibromyoma. What is the management?
Oh, yes. Okay, well,
unfortunately, the case died.
We're not oncologists. Well, thank you for really sharing this because I have a patient like that I'm currently managing. Let me tell you what I did. She's 37 years old with a multifibroid uterus, known to have multifibroid uterus. More recently, she had rapid progression of her fibroid growth. And then the gynecologist who is seeing her referred her to me because he didn't feel comfortable to deal with the case because of the combination infertility and fibroids. So when actually this during the COVID time, so I didn't even get to see the patient personally until now. I was managing through Zoom. So she has definitely rapidly increasing. She's presenting to the ER with pain. The immediate thing that came to my mind actually is to do chest X-ray on this patient. Leiomyosarcoma is prone to metastasis early on. And lo and behold, she has multiple cannonball metastases in her lungs. And that's how we figured out that she has leiomyosarcoma. So immediately she was transferred to an oncologist colleague who took her uterus out. So 2 things that you can do if you are suspecting that. You should not wait until you go for your surgery. You should have a high index of suspicion mentally, particularly if the patient is a high risk or the fibroid is growing, if it is tender, if the patient has any chest complaints of any sort. Do 2 things, chest X-ray, LDH, lactic dehydrogenase, which is a tumor marker. Not very sensitive. You can do CA-125, not very sensitive, but you're just gathering as much evidence as you can. And then MRI or CT, you will see lots of issues there. MRI can tell some changes that can be leiomyosarcomatous, and it can raise your suspicion that you're dealing with a leiomyosarcoma. In this case, then you have to do a big midline laparotomy on those patients, and hysterectomy and staging is a treatment. You forget about fertility. You're trying to save her life.
How to manage cervical intramural myoma?
Okay, another difficult question. I'll tell you what I do. Well, honestly, if it is only cervical, I found laparoscopic surgery to be easier than open surgery on those patients, irrespective of the size. So locate the fibroid. You have to know whether it is midline, to the right or to the left. And then that's what you do. If you're doing it open, let's talk about open. You go in the midline. I do phenosteel for most of those. Remember, fibroid surgery is not intra-abdominal surgery, although in some sort it's intra-abdominal. It's intramyometrial. Almost all of your maneuvers are within the myometrium, not within the peritoneal cavity. So if you manage to get into the myometrium, even if from a keyhole, you win 90% of the battle. So I go on the most bulging part of this myoma. I cut all the way until I see the fibroid. I don't start lateral dissection at all until I am in the right plane. And then I use a towel clip. Do you know the perforating towel clips that we use on the towels outside? Or a tenaculum, the tenaculum that you put on the cervix? You put it in the substance of the fibroid and you lift it up. Then it's completely out of its impaction inside the pelvis. And you can use a cautery actually to do circumferential shaving. Usually those fibroids are not surrounded with a lot of myometrium. You can be patient, and I use monopolar cautery all the way circumferentially, and it's completely dissected out of its bed. And then I spend as much time as I need to close it. So I think.
Can I have a question, please?
Yes,
Yes, sir. Go ahead.
Thank you, Professor Bedaiwy, for the very nice, elegant presentation. I'm asking about myomectomy before ICSI, especially type 3 fibroids and even fibroids type 4 and 5. Do you have a cutoff point, even if the fibroid is not touching or even not distorting the cavity? Because there is an evidence regarding fibroids. Some papers talked about 2.7 centimeters fibroid, some talked about 3 centimeters fibroid that has a negative impact on ART outcome. So I wonder what's your practice?
I can answer this question quickly, but I have to be excused after this because really I have another meeting. So I give a lecture. How about I give a lecture about non-cavity distorting fibroids and answer this question, Dr. Hassan?
Yes.
You will give us 3 lectures and 2 videos that will be put on our WhatsApp groups. I will talk to you about this.
I'm really sorry. I have somebody knocking in the door, so I am.
Yes, of course. Thank you very much. Thank you very, very much. And I will send you the rest of the question, Mohamed. Thank you very much.
Okay, thank you very much.